Hello and welcome everyone to this session in which we will be discussing case-based scenarios in medicine part 5. My name is Dr. Jhanvi. I'm the anesthesia educator on Unacademy. I hope all of you are able to see me and hear me well. So if the streaming and the sound is okay, please leave a thumbs up in the chat box. I will be able to see all of your I will be able to see all of your uh, comments in the chat box so I can see it. Okay, so this is going to be another interactive session as we have been having them every day. And let's begin with our class for today. I am an MBBS MD in anesthesiology. So if any of you all have any doubts about how is anesthesia as a subject, as a profession, I would be happy to solve it for you all. Now this is the Telegram channel Let's Crack NEET PG, which will actually give you the links to all of my classes that I've taken till now. So these classes that I have been taking have been for free. They have been on YouTube and they have been very, very useful for everyone who wants to practice before NEET PG on what kind of questions will come for the exam. We have the All India mock test of NEET PG 2022 on February 26th at 9 a.m. So I hope that all of you all do end up coming for that test because it will act like a mock test and give you an example of how your preparation is, because we still have 1.5 months to go, so you guys can increase your preparation rate as well as its quality. Now we have the NEET PG combat on the 19th of Feb 6 p.m. Why is it so exciting? Because you can win tablet, smartphone and Amazon vouchers in it. So yeah, that's definitely more exciting than even giving the NEET PG exam. And the Plus subscription on Unacademy will help you get access to the live and recorded classes. You can learn from India's top educators and you can compete in live tests and quizzes. The Iconic subscription will help you get access to both Unacademy and Prep Ladder. So you can get the video lectures of Prep Ladder along with the recorded lectures of Unacademy. These are our FMG toppers, and we also have the educator curated test series for every single subject. In our special classes, if you want to try out the Unacademy platform, you can come, you can attend the free special classes, you can talk to the educator while the class is on, and you can also download the PDF at the end of the class. Now, these are some of the plus batches that are going on right now. The Target Next 2023 subject-wise batch, the NEET PG 2022 All Educator Revision batch, Focus FMG Comprehensive batch, and Focus FMG December batch. We also have the NEET PG Plus subscription, which has been slashed highly. You can see that 3-month subscription is only for 11,250, and the Iconic subscription rates have also been reduced. Also, I have a anesthesia test series. The questions are very simple and you can win an Amazon voucher worth 5,000. This is on the 18th. I will be sharing the link of this test on Telegram. It's a very simple, straightforward half-an-hour test, and if you win this, you can win a 5,000 rupee Amazon voucher. So if you would like to buy the Plus subscription on Unacademy, please don't forget to use my code Dr.Jhanvi Live, with which you can get a discount on your Plus subscription. With that, let's begin our first question for today, and it is this. A person comes with the following oral lesion. He has limited mouth opening and he gives history of oral tobacco chewing since 20 years. What is the choice of the method of securing his airway? Supraglottic airway device, oral intubation, nasal intubation, or awake fiber optic intubation? Good morning, good evening, sorry, Karthik, Tharini, Naveen, all of you all. So what do you guys think is the choice of securing his airway? So all of you all are saying awake fiber optic intubation. Okay. Yes. So can you guys tell me? No, all of you who have mentioned answer as D, that is the correct answer. Now let's have a look at this question. What do we have in this question over here? So a person has come with the following oral lesion, correct? So in this oral lesion, what does he have? He has limited mouth opening and he has history of oral tobacco chewing. So what are we talking about over here? Any idea? Any idea what are we talking about in limited mouth opening and oral tobacco chewing? What is the problem that he is suffering from? Yes, so this patient is having oral submucous fibrosis. Okay, oral submucous fibrosis. Now, because of this oral submucous fibrosis, what has happened? There is, when you eat tambaku, and you keep it on the inner side of your cheek for some amount of time, because of the chronic irritation, there is fibrosis and there is limited mouth opening. So, because of the limited mouth opening, this patient is not able to open his mouth very well. It will be only be so much. In this limited mouth opening, you cannot pass a laryngoscope. So, if you cannot pass a laryngoscope, intubation is not possible. Remember guys, many of you all mark it as nasal intubation. In nasal intubation, only the endotracheal tube goes through the nose, okay? The laryngoscope is still going from the mouth only. So this mouth opening is not enough to pass the blade of the laryngoscope, okay? So both intubations are not possible in this case. And the only option that we have is supraglottic airway device or awake fiber optic intubation. Obviously, if the mouth opening is not enough for a laryngoscope, it will not be enough for a supraglottic airway device also. So you won't be able to pass that also. So the only option you have over here is an awake fiber optic intubation. Okay. Now, in a fiber optic intubation, what do? You do nothing but you take a very thin and I'll show you. It is something like this wire. Okay. So can you see this wire? So the fiber optic scope, just imagine this is the fiber optic scope with the camera at its end. You pass it through your nose and it goes down, down, down like this through the vocal cords, through the trachea. Once it is through in the vocal cords inside the trachea, what is the next thing that you do? You pass the endotracheal tube on top of it. Okay. So this acts like a railroading bronchoscope or a railroading mechanism which will help you pass a intubating tube into the trachea. Okay, so this is your awake fiber optic intubation. You don't need to give any kind of anesthetic agent to the patient while you're doing this. You don't need to give propofol. You don't need to give anything else to the patient. All right. Okay, moving on to our next question. What drug will not be given as a pre-medicant in this procedure? Midazolam, glycopyrrolate, atropine, or pantoprazole. So while I'm carrying out this awake fiber optic intubation, can you tell me what drug will not be given as a pre-medicant in this procedure? Okay, so there is a confusion over here. Some of you are saying D, some of you are saying A. Any other answers? Yes. So what is the problem that you see over here? The mouth opening of this patient is limited. Okay, mouth opening is not good enough. So as a result of this, what is happening? You are not able to access the airway very well. Now, if you are unsure about the airway of this patient, will you sedate him? No. If you sedate this patient and you are not able to secure his airway, in that case, this patient can die of hypoxia. Okay. If you sedate, his respiratory rate falls down, oxygen levels falls down, he starts desaturating. Meanwhile, you try to oxygenate him, ventilate him, intubate him, put an LMA, you're not able to do any of that because of the limited mouth opening. Okay. So you don't want to be in that soup of a procedure. So in a patient of a difficult airway, anticipated difficult airway, this is an anticipated difficult airway, you will never ever give the patient any kind of sedation or anesthetic agent or muscle relaxant. Okay, so this is highly contraindicated till you secure the airway by awake fiber optic intubation. Next, you can give glycopyrrolate and atropine as anti-sialogom. That will help in reducing the secretions of the patient. You can also give pantoprazole to the patient as a PPI. Okay, so it will reduce the gastric acidity. This can be given to the patient as a pre-medicate. Okay, but you will never give any sedation or muscle relaxation or anesthetic agent to this patient with the anticipated difficult airway. All right. Okay, moving on to our next question. So the picture that you guys see over here, what I have put right now, is of a fiber optic intubation being carried out in a mannequin. Okay, so can you see over here? I'll just trace it. You can see the fiber optic scope, the black one, which they are putting through the nose of the patient, and at the tip of the fiber optic scope there is a camera, so you can see all the structures of the airway on this monitor. You'll be able to see the trachea, you'll be able to see the cords, everything. Okay. So this is a procedure of fiber optic intubation. Now, what is the question over here? Which of these drugs will you avoid during the procedure of securing his airway? Atracurium, propofol, choline, or all of the above? Yes. So all of you who have answered the question as all of the above, that's absolutely correct. You will avoid all of these drugs during securing the airway of this patient. As I told you, it is a difficult airway and you have to do an awake FOI, awake fiber optic intubation. So you will avoid any kind of muscle relaxant, you will avoid any kind of anesthetic agent, and you will avoid this choline is also a muscle relaxant. Okay. All right. Moving on to our next question. So this is a series of questions on the same thing that is happening. So for those of you who have joined in later, this is the patient that we have. He has a limited mouth opening and we are not able to, we are thinking what is the best way to secure his airway. And we have arrived to the conclusion that awake fiber optic intubation is the best way to secure his airway. Now, we have decided we will avoid any kind of sedation, muscle relaxant before the procedure is carried out. Now, the procedure is started and you have put the fiber optic bronchoscope, you have reached the trachea. Okay, this is the fiber optic bronchoscope. It has reached into my trachea. Now you're on top of the fiber optic bronchoscope, you're railroading the endotracheal tube. While railroading the endotracheal tube, the endotracheal tube hits a nasal turbinate, okay, and it starts bleeding profusely. What should be your next step? So initially you have such a nice picture over here of the vocal cords and the fiber optic bronchoscope has gone in. Now you're trying to put the endotracheal tube through the nose, but the endotracheal tube has hit a turbinate, and because of the bleeding, the picture that you can see through the fiber optic bronchoscope now is B and C. So what will be your next step in this case? Give tranexamic acid and continue, suction the blood and continue, blind passage of tube, or request a surgical tracheostomy. What will you do? Okay, now I can see a lot of confusion. B, D, B, D. Okay, just a second. Let me move the image a little bit because I guess you guys are not able to see the entire question. Okay, all right. So now you all are able to see the options. Fine. So let's evaluate each and every option that we have over here. We are definitely not able to see the airway, the tube, the fiber optic bronchoscope. None of that can be seen well. Okay, so should we give tranexamic acid and continue? Tranexamic acid is an antifibrinolytic. It will stop the clots from breaking, but it is not going to stop the bleeding at all. Okay, so as a result of this, what can we do? We cannot wait for the tranexamic acid to act and then the bleeding to stop and then continue. You don't have that much time. So this is not one of the options that can be done. Next, can you suction the blood and continue? Now, you know that your nasal cavity is highly vascular in nature. So there are a lot of bleeders that are there in the nasal cavity. You may have hit a small artery or a capillary, which may not stop bleeding even if you suction. Okay, so you keep on suctioning, the blood will keep on coming. So you cannot suction and continue. The problem with a fiber optic intubation is once it gets obscured by all this bleeding, you cannot see any part of the airway. Okay, so will you pass the tube blindly over the fiber optic bronchoscope? No, that should also not be done. What should be done in this case is that you should conclude that you will not be able to see the airway in this case, and since you have not given any drugs to the patient is still breathing spontaneously on his own, you are in a safe place over here. So what you do is you call the ENT surgeon or the surgery person and you ask them to do a tracheostomy, because this is an anticipated difficult airway. So you should not play with the airway of this patient. You should be safe and you should request for a surgical tracheostomy. Okay, remember, even if you suction the blood in the nasal cavity, it's so vascular that it can continue to bleed and you will still not be able to see any part of the airway. So the correct answer over here is you will request for a surgical tracheostomy. All right. So I hope you guys enjoyed this series of questions. It was all about how do you manage a difficult airway. So since we are discussing a difficult airway, this was an anticipated difficult airway. Okay. Now, in case of an unanticipated difficult airway, so suppose, for example, I go in for some surgery and do I look like a difficult airway? No, my mouth opening is fine. My mouth opening is good. My jaw looks fine. There are no masses outside. You'll feel like, she's an ASA1 patient. Her airway is not going to be difficult. Okay. Now, suppose when the anesthetist is trying to intubate me, they try 3, 4, 5 times. They are unable to intubate me. So I turn out to be an unanticipated difficult airway. So unanticipated difficult airway is defined as an airway where you have difficulty in mask ventilation, difficulty in LMA insertion, difficulty in intubation, or difficulty in all of them, and all of this was unanticipated in the PSC. So there are difficult airway guidelines by the Difficult Airway Society, which you should 100% know, because this is one of the important questions that comes in the exam. It's a clinical based question. So suppose I'm going in for surgery, and the first thing that the anesthetist tries is tries to intubate me. So how many times can I allow a maximum intubation in my patient? Like, should they keep trying to intubate till they can put the tube through my vocal cords, or should they stop at some number? Yes, Ayush, I will do that once I get done with the difficult airway guidelines. So can you guys tell me how many maximum attempts of intubation I can take in a patient? Or can I keep trying till I get the vocal cords, tube through the vocal cords? Yeah, so the maximum attempts of intubation that I can do is 4. Okay, now I remember this 4 as 3 plus 1. Why do I remember this as 3 plus 1? Because 3 intubations can be done by anyone, but the last intubation should be done only by the senior most person in the OT. Okay, so actually number of intubations allowed is number of attempts allowed at intubation are 4, but I remember it as 3 plus 1 because that plus 1 means the last should be tried by the senior most person in the OT. Now, if after 4 attempts at intubation I am not able to intubate, what is the next step that I should do in that case? Anyone? If after 4 attempts intubation is not possible. Yes, absolutely correct. So in that case, I should try for a supraglottic airway device insertion. I will try for a supraglottic airway device insertion. Okay. So in the supraglottic airway device insertion, if how many attempts can I take? At supraglottic airway device insertion, how many attempts can I take? Yeah, so here also I can try for a maximum of 3 times. Okay. Once my supraglottic airway device is also not going in, what is the next step that I should do in that case? So I have tried 3 attempts at supraglottic airway device also. That is also not possible. So the next thing that I can do is, anyone, any idea? I can bag and mask ventilate the patient. Now I'm getting scared because even oxygen is not going past my patient and his saturation is dropping. So the next thing I do is just try to maintain the oxygenation in this patient by doing a bag and mask ventilation. Okay. Now, suppose bag and mask ventilation is also not possible. Many a times what happens is because you do a lot of khach kuch kuch while putting the supraglottic airway device or intubation, you cause bleeding inside the airway, and that can cause to bronchospasm. And now the patient is not even getting ventilated. So if my patient is not even getting ventilated, the next thing I do is a front of neck access. Okay. Next thing I do is a front of neck access. So in a front of neck access, what is the method that I go through? In a front of neck access, I can do either a tracheostomy or I can do a cricothyroidotomy. Okay, so I can either do a tracheostomy or a cricothyroidotomy. So what do I do in a tracheostomy? Nothing. I just cut through the front part of the neck, cut through the trachea, and then insert a tracheostomy tube. Or what is a cricothyroidotomy? Cricothyroidotomy, I feel for the thyroid cartilage, feel for the cricoid cartilage, and then in between the two of them, I just pass the cricothyroid, a big 16 gauge cannula, which will act like a ventilating tube. Okay, so everyone feel for the most prominent part of your neck, that is your thyroid cartilage. Then feel for the C-shaped cartilage that is there below, that is your cricoid cartilage. So in between the two of them, you have a depression, which is the cricothyroid membrane. So through the cricothyroid membrane, just pass your 16 gauge IV cannula, remove the stellate and ventilate the patient from outside. So that is your front of neck access. Okay, got it? All right. So that is my difficult airway guidelines in case of an unanticipated difficult airway. And for all of you all who are asking me to repeat the entire series of questions that I told you, in case of anticipated difficult airway, what are you supposed to do? In case of an anticipated difficult airway, you are supposed to directly go for awake fiber optic intubation. Okay, you just put the fiber optic through the nose. You can see with the camera, this is the picture of how a fiber optic intubation is done. You can see with the camera, go inside the trachea, and on top of that, pass the endotracheal tube. So that is your awake fiber optic intubation. Okay, guys, clear? Alright, so that's how you manage your anticipated and unanticipated difficult airway. Now moving on to our next question. In a female who has missed her menstrual period and urine pregnancy test shows weakly positive remark, what would the next step be? So this is from Gynac. Repeat UPT to a total of 3 times, trans-abdominal, USG, transvaginal ultrasound, serum beta HCG levels. Okay, so again there is a lot of confusion in this question. Can you please tell me what is the answer? The streaming is okay now? Alright, okay, so we can continue with our class. Alright, next question for you guys. A 4-year-old 12 kg child is posted for a short procedure, MRI brain scan under general anesthesia. What size supraglottic airway device would you insert? Size 1, size 1.5, size 2 or size 2.5? Okay. Can you guys see the question? Yes, most of you are able to see the question and I can see the answers pouring in now. So for here, you should know the basic sizes of the LMA and when do you use them. So if we see, the ones that I always tell everyone to everyone to remember is size 3. It's the easiest to remember. Okay, size 3. 3 ka 3 you can write over here and then add a 0 over here. So size 3 can be used in 30 to 50 kg. And then the next size is size 4, which we use in 50 to 70 kg. Okay. So what do we have over here? Size 3 and size 4. Correct? Earlier question. Okay. Earlier question is, we already discussed the earlier question. You will look for doubling of the serum beta HCG levels in 48 hours to confirm the pregnancy. Okay. All right. This one, the LMAs that you need to remember is size 3 and size 4, and then you need to remember the smallest size of LMA, that is size 1, and that is used in the smallest size of patient, that is a neonate. Neonate is usually 3, 4, 5 kgs, not more than that. So a neonate is less than 5 kgs. Okay. So what we do over here now, next is you have to find out 12 kg child में कितना use होता है, correct? So just imagine that if size 1 is less than 5 kg, size 1.5 is between 5 to 10 kg, size 2 will be 10 to 20 kg. Okay, so these will be your sizes. So in this child, he is 12 kg, so you will be using a size 2 in him. Alright, so the answer over here is nothing but size 2. Size 2 LMA will be used in a child who is 12 kgs. Okay, and then suppose I give you 25 kg child, mein what size will you use? So you know that size 3 is used in 30 kg. So 25 kg is one step lesser than 30. So you will use a smaller size over here. So you will use size 2.5. That is the one that is used between 20 to 30 kg. Okay. So the answer over here is size 2. Okay. Moving on to our next question. So now for the MRI, you have given GA, you have put size 2 LMA, the MRI procedure has started, and half an hour into the procedure, when the MRI technician starts taking the contrast enhanced images, the child starts desaturating. What should be done in this case? Readjust LMA as it must have moved, increase depth of anesthesia as child must be in light plane of anesthesia, give adrenaline hydrocort and phenyramine maleate, abort procedure. What should be done in this case? So imagine you're in the MRI room and the child is desaturating. Suddenly you don't know what has happened. The technician is saying, I didn't do anything, I just gave contrast and I came outside. You're wondering what has gone wrong. Meanwhile, the saturation has become 90, 80, 70, 60. What will you do? Okay, so a lot of you are messaging give adrenaline, hydrocort and phenyramine maleate. Now, can you tell me what is making you think that that would be the answer? And some of you all are saying abort procedure. Okay, Karthik, even if I abort the procedure, the child is desaturating. His saturation is going down 70, 60, 50. What do I do? I can stop the MRI, but how can I stop the saturation from falling? Come on, put yourself in that situation and try to think on the spot. So why do you think that this has happened? Why do you think the situation has arisen? Anyone? Very good, Meena. Excellent answer. Okay. So the answer is given in the question itself. They have told you that while taking the contrast enhanced images, the child has started desaturating. Okay. So what is the problem that has happened over here? The problem is that while taking the contrast enhanced images, because of the contrast, the child has got an anaphylactic reaction. Okay. Now, what does anaphylaxis do? Anaphylaxis can lead to bronchospasm, and because of that, the child is desaturating. So, what will you do to counter the anaphylaxis? You will give adrenaline hydrocort and phenyramine maleate. That will take care of the anaphylaxis and cause bronchodilation again. Okay. Now, there is one concept that I want you guys to know over here, and that is about laryngospasm versus bronchospasm. Okay, so look at this. What is laryngospasm? What is bronchospasm? So if you look at the trachea, and this is the bronchi. Okay, at the top of it, where the trachea starts, you have the vocal cords. Okay, the same thing I will draw for you over here. Now, what is the problem happening in case of laryngospasm? In laryngospasm, your vocal cords are shutting completely. So when your vocal cords shut completely, what happens? No air can go in, and no air can come out. Okay. What happens in case of bronchospasm? In case of bronchospasm, these bronchi that are there, they become narrowed. The smooth muscle that is there inside it gets contracted. Okay, so these bronchi get narrowed. So as a result of this, the air entry is there. It's not like laryngospasm that there is complete silent chest and no air. But here, the air entry and the air exit takes some time to happen. Okay, because of the narrowed bronchi. So you will be able to hear a wheeze in this case. But in case of a laryngospasm, it is a silent chest. Okay. So this is what you need to know about the difference between laryngospasm and bronchospasm. In case of anaphylaxis, we mostly get bronchospasm. How will you diagnose it? You auscultate the patient and you will be able to hear a wheeze. All right. Okay. Moving on to our next question. A 50-year-old male chronic alcoholic with liver cirrhosis comes to the casualty disoriented and breathless due to abdominal distension. Which of these will help to know the metabolic regulatory functions of the liver? Serum albumin, serum ammonia, blood glucose, or total bilirubin? Alright, so the correct answer over here is nothing but blood glucose. So for this, you need to know the functions of the liver. In fact, recently only we have discussed this question about the different functions of the liver. So you should be knowing all of them. So your serum albumin is what kind of function of the liver? It is nothing but synthetic function of the liver. All your plasma proteins, albumin, clotting factors, all of these are the ones that are produced in the liver. So this is a synthetic function of the liver. Your serum ammonia. Ammonia is nothing but a detoxification function of the liver. Okay. Or excretory function of the liver. Production of serum ammonia. Your total bilirubin. What is your total bilirubin production? Then your anyone. Total bilirubin is what? Your carbohydrate, protein, and fat metabolism is the metabolic function of the liver. Okay, so that is why your blood glucose levels will come in this. On the other hand, what are your other things? Your bilirubin, was the secretory function of the liver. Okay, so you should be individually knowing all the functions of the liver. Only then you will be able to answer this in the exam. It is a very basic physiology question that all of you all should know. Alright, moving on to our next question. A Jehovah's Witness is posted for major aortic repair surgery. Which of these would be sensible to be done pre-operatively for the patient? Keeping donor matched blood ready, pre-op erythropoietin injections, autologous blood. Okay, Batao, what is the answer to this question? Alright, so what is a Jehovah's Witness? For all of you all who are answering this question, first tell me what is a Jehovah's Witness? Anyone? An aortic repair surgery, so basically they are trying to tell you that this is a major vascular surgery, so there is going to be a lot of blood loss. So if there is going to be a lot of blood loss, you will require to transfuse a good amount of blood to this patient, correct? So PSK is saying that the answer is C, autologous blood transfusion. In some, Karthik, all of them are saying C, but can you tell me what is a Jehovah's Witness first of all? All of you are wrong. Everyone who's answering C is wrong. Okay. So Jehovah's Witness, basically from medical point of view, it is important for us. It's because they believe that they should not be taking any blood products from outside. Okay, so once the blood leaves their body, they cannot take any blood or blood products from outside. So they don't take blood transfusions, they don't take platelet transfusion, they don't take plasma transfusion, nothing. Okay, so nothing from outside. So if the patient is undergoing a major repair surgery and he may require blood transfusion intra because of the blood loss that is anticipated, you have no other option but to build up his pre-op hemoglobin. Okay, so remember, in Jehovah's Witness, they will neither take any blood from another person, even if their own blood leaves the body. Like suppose you tell them ki let's take your own blood and we'll pack it and keep it, and during the time of the surgery we'll transfuse you with it. Even that is not allowed. Once the blood leaves their body, then they cannot take it back. Okay, so they won't take autologous blood transfusion also. Autologous blood transfusion means taking your own blood back. Okay, or they don't allow platelet transfusion also. So none of them will be allowed. So the only thing you can do in them is to build up their pre-operative hemoglobin so that they can tolerate the blood loss during the surgery. All right. Okay. After total thyroidectomy, patient comes home. After 48 hours, he starts complaining of perioral tingling and numbness. He also shows the following sign. What is this sign called? Schwastek sign, Truser sign, Furchow sign, or Trousseau sign? Okay. So I can see that most of you have answered it correctly as D, Trousseau sign. A few of you are confused between B, Troussier sign, and D, Trousseau sign. So that was my intention, to confuse you all. So definitely after total thyroidectomy, what have you done? You have removed the entire thyroid. Along with the thyroid, what have you done? You have also removed the parathyroids. So after 48 hours, your parathormone level starts falling. Okay. So your parathormone is nothing but the hormone that will help in maintaining calcium levels in the blood. Okay. So if your parathormone levels are falling over here after 48 hours, what do you start getting? You start getting signs of hypocalcemia. So what are your signs of hypocalcemia? Perioral tingling and numbness. Okay. So that is the first sign that you see. Along with that, you see two other signs. Hypocalcemia therny, not hypercalcemia. So you see two other signs. One is when you tap the facial nerve distribution and you start getting a twitch on your cheek. Okay, so that is called as Schwastek sign. Schwastek sign. Okay, and the second thing that you get is when you attach the BP cuff on the hand and inflate the BP cuff, you will get a claw hand. Okay, you will get clawing of the fingers. That is called as the Trousseau sign. So you get the Schwastek sign and the Trousseau sign. Okay, so what is the answer over here? The answer is Trousseau sign. Now, can anyone tell me what is Troisier sign? Because many of you all were confused with this. Can you tell me what is Troisier sign? Anyone? In which condition do we see Troisier sign? Very good. Very good in some. So in case of Furchow's node, we will see Troisier sign. What is Furchow's node? It's not Furchow's sign, it is Furchow's nodes. Okay. Yeah. So it is nothing but left supraclavicular lymph node pathy. Okay. So your lymph nodes on the left side, left supraclavicular side, are enlarged because of metastasis from CA stomach. Okay. So your metastasis from CA stomach, due to which you get the enlargement of the left supraclavicular lymph nodes, that is called as Troisier sign. All right. Okay. Another metastasis that you get in CA stomach to the umbilicus is called as Sister Mary Joseph nodule. So all those things you also remember, those names, because they love to ask those names in the exam. Okay. All right. Next question. So this is from FMT. A man gets into a fight in which he sustains head trauma. His post-mortem shows this image. What type of fracture is the below skull fracture? Depressed fracture, ring fracture, comminuted fracture, or linear fissure fracture? Nothing is stuck now. It's going on as usual. Just because I'm not moving, you all are thinking that it is stuck. Mask-like face. Seen in which disease? Mask-like face is seen in which disease? Okay, so correct. All of you who are answering it correctly, this is a comminuted fracture. Okay, so this is a comminuted fracture of the skull in which what do you get? You get broken pieces of the bone. So the skull bone is broken into many pieces, as you guys can see. But what is the problem over here? This is a undisplaced comminuted fracture. Remember that. Okay, so the pieces of the bone are not displaced from each other. This is a undisplaced comminuted fracture. That's the important thing that you need to remember. Now, if we look at the other fractures of the skull, and why am I showing you this? Because this was asked in INI-CET of 2022 to identify the fractures of the skull. So if you have a single line that is fractured, that is called as a linear fracture. If you cannot see any external signs of the fracture, but the inner table of the skull is depressed, that is called as a depressed fracture. Okay. Then can you see over here, what do you have? Along the suture lines, if you are getting the along the coronal suture and the sagittal suture, if you are getting the fracture, that is called as diastatic fracture. Now this diastatic fracture is important because this is exclusively seen in pediatric patients, especially the ones below 1 year of age, because their suture lines have not yet closed. So this is diastatic fracture. And then basilar fracture is at the level of the base of the brain. Okay, so here your medulla will get affected, and as a result of this, since your respiratory center and hemodynamic center are present over here, basically your patient can die immediately because of that fracture. Okay, so that is your basilar fracture. And then you have the transforaminal fracture, which will be through the foramen magnum. All right, so these are all your different types of skull fractures that you should be aware of. Okay, next question. An intern has been asked to collect blood for coagulation testing. Which colored bulb should he pick? Purple, blue, green, or red? So this was also asked in INI-CET 2020. You should know all the different colors of bulbs and what is the testing done in them and what is the additive added in that case. Yes, very good. So most of you have answered it correctly as B, blue. So coagulation testing is done in blue. So now let's go for each and every question that we have and discuss it. So in a purple bulb, can you tell me what is the additive and what do you collect? What is the test done and what is the additive? Tell me for each and every bulb like that. Already blue bulb we have discussed. What will you do in a blue bulb? You will do coagulation testing. So basically you will check your PT-INR levels. Barabar? So what is added in the blue bulb? In the blue bulb we add citrate. Yes, very good. Tharani, EDTA bulb is the purple bulb. So the additive here is EDTA. And what do we check over here? We mainly do our CBC. Okay, so our complete blood count is done in this case. And also our blood grouping cross matching, you need EDTA bulb as well as your red bulb, plain bulb. Okay. Then green bulb, what is the additive? Green bulb additive is heparin, and the test that is done in case of green bulb is serum electrolytes. Okay, so your RFT and serum electrolytes, that is your sodium, potassium, chloride, magnesium, creatinine, all of those are done in your green bulb. Okay. Next we have the red bulb. This is nothing but the plain bulb. So plain bulb, basically you want to collect it for the serum. You're not going to add any additive in that. So the blood will clot over here. So you can do your triple H testing over here. Your HIV, hepatitis B, hepatitis C, all those testing. Then for blood grouping, cross matching, you require this. Then for checking antibody levels for many things, you require this. Okay. So this is your red blood bulb. Then you also have a clot activator bulb. Clot activator, so instead of adding in this red bulb, instead of having this, you will have a yellow colored cap. So yellow colored cap bulb basically has a clot activator in it. So that helps in quicker clotting and separation of the serum. Okay. So this yellow bulb has nothing but a clot activator. That is also used for doing the same tests. Okay. Alright. So these are all the different types of bulbs that we have and the tests that you will do in them. We have one more I forgot to add, and that was our gray bulb. So in gray bulb, the additive, as all of us know, is sodium fluoride. It's called as a fluoride bulb. And what do you check in that? You will check your sugar levels. So you will check your glucose levels in that. Okay. So FBS, PPBS, all of them. Alright. Next one. This is an X-ray post central line insertion in the ER. What is the next step? Start vasopressors medications through the central line, reinsert in the femoral vein, ask for radiology consult on the X-ray, or reinsert in the same vein. So look at the central line, look at where it is going, look at the position, look at the lungs, and look at the arrangement of the line. Is it a straight line? Is it a tortuous line? Is it a curved line? What will you do? A, B, A, B, A, B. Everyone is getting confused between them. Okay, Tharani's saying I will reinsert it in the central vein, and Karthik is also saying that femoral vein. Why would you reinsert it in the femoral vein? Can you please give me any idea? Why would you want to reinsert the central line into another vein? There has to be a logical reason behind the answers that you guys give, correct? So try to think, is there anything that you would like to change in this line? Okay, so let's have a look at this X-ray. Just trace my line from here. Can you see? It is going into the right side of the heart. So it is reaching the correct place. So where is it reaching in the right side of the heart? At the junction of the SVC and the RA. Junction of the SVC and the RA. Okay. So is that the correct place? Yes, because the tip of the central line should reach between the SVC and the RA. So it's absolutely the correct place where it should reach. So the central line is in the correct place. And the next thing that I need to see is, while putting the central line, have I caused any pneumothorax? So I can see that the lung markings are well present over here. The lung is inflated. There is no pneumothorax. So there is no problem with this line. I can continue to use my line. Alright. So I can go ahead and start whatever I want to give through this line. I can start vasopressors. I can start medications. There is absolutely no problem with this line. I do not need to reinsert it anywhere else, nor do I need to ask radiology consult on the X-ray. Okay. Alright. A pregnant woman with placenta previa is taken for emergency LSCS. During the surgery, She has major blood loss and cardiac arrest on the table. In how much time should a perimortem cesarean delivery be carried out? 1 minute, 4 minutes, 2.5 minutes, or 5 minutes? बताओ ACLS guidelines. What is the answer? Perimortem cesarean delivery to be carried out in how much time? As per ACLS guidelines. Okay, so there is a little bit of a dilemma in this question. Okay, so there is a rule which is called as the 4-minute rule. Barabar? 4-minute rule. Now, what does the 4-minute rule say? 4-minute rule says that you should give CPR to the mother for 4 minutes, and by the 5th minute, the baby should be out. Okay? So, by the 5th minute, baby should be out. If you ask me, in how much time should a perimortem cesarean delivery be carried out? So in that case, my answer would be 5 minutes, because by the 5th minute, the baby will be out. So the cesarean delivery will be done by the 5th minute. So the answer would be 5 minutes and not 4 minutes. Okay. So if they ask you for how long CPR should be given to the mother, you should say 4 minutes. If they say by when should the perimortem cesarean delivery be carried out, then your answer should be 5 minutes. All right. Okay. What is the next step after seeing the below X-ray? Insert a drain, CT abdomen, emergency exploratory laparotomy, Ryle's tube insertion to suction out the gastric air. Okay, again, there's a lot of confusion. B, C, D, all the options I've got except A. No one wants to insert a drain in this patient, huh? Alright, so can anyone tell me what is the diagnosis through this X-ray? What is the diagnosis, guys? Yes, very good, Meena. So what is this sign called as? This sign is called as the coffee bean sign, or it is also called as the bent inner tube sign. So your coffee bean sign or bent inner tube sign. And in which condition do we see this? We see this in case of sigmoid volvulus. So in sigmoid volvulus, we see the coffee bean sign or the bent inner tube sign. And the treatment for this is nothing but emergency exploratory laparotomy, so that you can untwist the volvulus and you can decompress the bowel. Okay. Now, many of you all are saying CT abdomen. You have already got the diagnosis, clear diagnosis from the X-ray. There is no point doing another radiological investigation. So no. Insert a drain, that is not going to take care of the twisting of the bowel. Ryle's tube insertion to suction out the gastric air. This air that is there is in the colon, which is obstructed. It is not in the stomach. Raleigh tube is only going to reach up to your stomach. The problem is in the sigmoid colon. So that is also can be ruled out very logically. So remember, when you get these kind of questions, now think a little more logically and rule out the options. There is no point just thinking ki हाँ ऐसे हो सकता है वैसे हो सकता है and then getting confused. Okay. So your answer is emergency exploratory laparotomy, untwist the bowel and decompress the bowel. Alright. Okay. This deformity is seen in which condition? Sorry. Osteoarthritis, rheumatoid arthritis, gout or psoriatic arthritis? Batao jaldi, what is the name of this deformity and in which condition is it seen? Very good in some. So the deformity that you can see is your swan neck deformity. This is your swan neck deformity. Okay. So your swan neck deformity is seen in which condition? Swan neck deformity is seen in case of rheumatoid arthritis. Very good. Now, can you tell me, if you are talking about osteoarthritis, what is the deformity that we see? We see two swellings. One is at the PIP and one is at the DIP, proximal and distal interphalangeal joint. So can you guys tell me what is the name of those deformities that you see in osteoarthritis? Yeah, so you see the Hebden's nodes and the Bouchard's nodes. Barabar, you see Hebden's nodes and Bouchard's nodes. Hebden's nodes is seen in the distal interphalangeal joint, and your Bouchard's nodes is seen in the proximal interphalangeal joint. How do I remember this? B comes before H in A, B, C, D, E, F, G, H. B comes before H. So B will be proximal and D will be distal. Okay. So that is in osteoarthritis. In rheumatoid arthritis, you see swan neck deformity. You also see Z deformity of the hand. Z deformity of the hand or ulnar deviation of the hand, that is also seen. Okay. In gout, what do you see? In gout, what do you see? In psoriasis, what do you see? You should know all the different deformities and in which conditions you see them. Very good. In gout, we see tophy. That is a clinical sign. So in gout, mainly your great toe will be affected. Okay. And what is the sign that we see in psoriatic arthritis? It is called as pencil in cup deformity. Pencil in cup deformity. So these things you should be aware of for each and every diagnosis of connective tissue disorders, because they tend to ask this in the exam. Okay, next question. Post esophageal surgery, patient becomes suddenly breathless and starts desaturating. Give the diagnosis in this case. Left lower lobe pneumonia, rupture of the esophagus, acute pulmonary edema or pericardial effusion. Okay, so most of you all are answering it correctly as acute pulmonary edema. Now, can you tell me why is this acute pulmonary edema? What do you see in the chest X-ray over here? Very good. I'm very impressed with all of you all. Huh? बराबर आंसर किया. Why can't it be pericardial effusion or rupture esophagus or left lower lobe pneumonia? Okay, chalo. Left lower lobe pneumonia would have presented with a consolidated lobe, so that is out. Rupture esophagus would have presented with presence of effusion over any one side. Okay, so on the left side, because the esophagus has ruptured there. But here you can see bilateral presence of opacities. And pericardial effusion would have presented as a water bottle heart. That is also not seen. So what is the sign that you see with which you can conclude that this is acute pulmonary edema? Anyone, can you give me the name of that sign? What is the name of that sign? Yes, very good. So this is called as the bat wing appearance. So can you see over here? This is called as the bat wing appearance. So imagine this is the bat, and the bat wing appearance is technically seen in acute pulmonary edema. All right. Okay, next question. A patient is undergoing LSCS and receives one packed red blood cell. 2 hours later, in the recovery, she develops hypoxemia, dyspnea, cyanosis, fever, tachycardia, hypotension. The chest X-ray is given in the image below. She has received blood 1 year ago also, but that was uneventful. Give the diagnosis in this case. Mismatched blood transfusion, TRALI, TACO, or anaphylaxis. Now, I know you guys have seen a similar question before, and we have discussed each and every option. So hopefully this time you all will not make a mistake in this. TRALI, any other answers? Chalo, quickly tell. Otherwise, how will we complete the session? Very good. So all of you have answered it perfectly. No Atmesh, no Mulai. This is not taco. Last time it was taco. Now I have made some changes to the question, and the answer over here is TRALI. The answer over here is TRALI. Okay, so what is happening over here? The patient is undergoing lower segment cesarean section. Okay, and she is receiving only one packed red blood cell. So if the transfusion is only one packed red blood cell, what is the diagnosis that is out of the question? TACO. What is TACO? TACO is nothing but transfusion associated circulatory overload. What is happening over here? Because of excessive blood transfusion, you can have circulatory overload. Okay, so because of that, what are you supposed to do in that case? You're supposed to give Lasix to the patient and remove the excessive transfusion that you have done. Okay, so Lasix will help in removing the circulatory overload part, but here the patient has received just one PRBC, so you don't need to, this is out of question. Next, she has received blood 1 year ago also, and that was uneventful, so anaphylaxis to blood is also out of the question. So your two options here are mismatched blood transfusion and TRALI. Now, the problem that is happening in the patient is happening 2 hours later. If it was a mismatched blood transfusion, you would have immediately seen the symptoms. So that is also out. So the only answer we have over here is TRALI. So that is how you get to the answer by the ruling out method. Other than that, agar tumko dekhna tha, so in the chest X-ray, what are you able to see? You are able to see the infiltrates in the pulmonary vessels. Okay. So what are these infiltrates in the pulmonary vessel? This is nothing but antigen antibody immune complexes. Antigen antibody immune complexes that you see lodged inside the pulmonary capillaries. All right. So the answer here is TRALI. Okay. How will you treat it? Nothing. You have to give steroids to the patient. You have to give positive pressure ventilation to the patient, and the patient will be fine. A 25-year-old man met with a motorbike accident without a helmet. He was taken to the hospital in an unconscious state. On arrival to emergency room, his heart rate is 56 beats per minute, BP is 150 by 90, SpO2 is 100, GCS is 7. Which of these is correct regarding intubation? Intubate an OT by expert, intubate immediately, intubate after CT report, or intubate only if patient desaturates. Okay. So we have Tharni and Insam saying the answer is intubate immediately. Why? No one wants to be intubated by the expert anesthesiologist? Why everyone is answering it as B? Okay, but all of you are unfortunately or fortunately correct about it. So, what is the problem over here that we are seeing? We are seeing everything, he is unconscious, he is arriving to the emergency room, all that blah blah blah. But his GCS is 7. In a patient who has a GCS lower than 8, what is the risk that we have over here? The risk that we have over here is risk of aspiration of gastric contents. We have a risk of aspiration of gastric contents. So because of this, what will we do? We will intubate the patient immediately. Okay, GCS less than 8, you have to intubate to protect the airway, not to ventilate the patient, but to protect the airway. Okay. All right. This is the CT scan of this patient whom you have intubated. What is the likely diagnosis in this case? Subdural hematoma, intraventricular hemorrhage, intraparenchymal contusions, or extradural hematoma? Okay, what is this appearance that you see? What is the name of this appearance? Extradural hematoma is absolutely correct. What is the name of this appearance that we see in EDH? Yes, so it is called as a biconvex appearance, or I also call it as the Eadley appearance. So it looks like an Eadley. So E for Eadley. E for Eadley. Okay, so extradural hematoma or Eadley. Okay. So can you guys tell me what do I see in A, what do I see in B, and what do I see in C? Write in the chat box what is seen in A, what is seen in B, and what is seen in C. एग्जाम में आए थे ये क्वेश्चंस, इसलिए तो आना होता है क्लास में. ओके, DK is saying A is SDH. Yes, you're absolutely correct. So your lenticular shaped opacity that you see, this is nothing but subdural hemorrhage. Okay, this is our subdural hemorrhage. Okay, barabar. What is B? कुछ आइडिया है या नहीं? See where the blood is present. I have given you 3 other things that you can identify, and then you have the blood here. This is intraventricular hemorrhage. The blood is in the ventricles. Okay, so this is intraventricular hemorrhage. And what about C? C is similar to something that you all have answered before. Okay, so guys, over here you can even see midline shift. Can you see? This side ventricle is completely compressed and there is a midline shift over here. Okay, and C may, you can see the presence of blood over here. This is also lenticular shaped, but this blood is looking blackish in color, correct? So this is nothing but old SDH. So this could be a chronic SDH or old SDH. So whenever your blood looks bright, it is acute SDH. Whenever your blood looks darker, it is a chronic SDH. Okay. So that is what you guys should be knowing about in case of different types of CT scan. So your EDH, SDH, acute as well as chronic and intraventricular hemorrhage. Okay, next question. I think this would be our last question for today. No, we have two more questions left. So an 18-year-old patient undergoes posterior fossa surgery. Blood loss is 1 liter. Post-operative vitals are stable. Patient is breathing but not opening his eyes. A CT scan is done. What does it show? Normal, residual blood in brain, pneumoencephalus, or active bleeding in brain? Mrityunjay, infarct means the blood is not reaching the brain. There is ischemic area in the brain. Okay, there is in some there is no air embolism over here. Alright, so he is undergoing surgery. That means there is some surgery that is going on for the cerebellum or the medulla. Okay, blood loss is there. All this they have written time pass only. But what are they telling you which is important, that the patient is not opening his eyes, so he is not waking up at the end of surgery. And what can you see in the CT scan? You can see that there is something collected in the front. And what is this that is collected in the front? This is nothing but air. Okay, so when you open up the dura, some air gets trapped inside, and as a result of this you get air collection in the cranial cavity. So when you're closing the dura, this air must have been trapped. So this is called as the Mount Fuji sign. Mount Fuji sign. Okay? Now, in other words, this air that is trapped inside is called as pneumoencephalus. Air in the brain. So pneumoencephalus. Alright. So this Mount Fuji sign or pneumoencephalus that we are seeing over here can lead to delayed awakening of the patient. So what can you do? Either you wait and watch for some time and the pneumoencephalus will get resolved on its own and patient will wake up, or if that does not happen, this is a surgical it's a nitrogenic injury only. Okay, if that does not happen, then you will have to aspirate that air out so that the brain can expand again. All right, so this is about your pneumoencephalus. Okay, and the last question for today. What does this X-ray suggest? Pleural effusion, lung consolidation, congestive cardiac failure, or acute respiratory distress syndrome? Batao, what does this X-ray suggest? Anyone? Again, what is the sign that you see on X-ray over here? Okay, so we have Eja saying lung consolidation, we have Insum and decay, and Tarini saying congestive cardiac failure, and we have Sohan saying pleural effusion. So everyone is giving different answers. So should we go with whose answer? Yeah, so Tarini has given us the right appearance of this disease. So this is nothing but bat wing appearance. We saw it previously also in the question I told you, esophageal rupture wala. Okay, so this is nothing but bat wing disease. So in this bat wing disease, this is mainly due to cardiac failure, left ventricular failure, congestive cardiac failure. That is the answer that we have. Okay, bat wing appearance. Clear? So quickly just going through all the questions that we did today: congestive cardiac failure, pneumoencephalus, EDH, then this was Trali, this was also bat wing appearance, this was rheumatoid arthritis, swan neck deformity, sigmoid volvulus, and then we have central line inserted properly, different types of bulbs for collecting blood for testing, and then we have your comminuted skull fracture, Trousseau sign. Okay, and then this was about our awake fiber optic intubation and all the complications that come with that. So the last thing that I want to tell you guys is that tomorrow's lecture will be in the morning at 10 a.m. So I'll post the link on this Telegram group for you. So this is the Telegram group, Let's Crack NEET PG, that I'll post the link for the class. I'll post it tonight itself. So I hope that all of you all will join me today for another set of case-based scenarios. All right. So, and please don't forget to leave a thumbs up at the end of the class if you liked it. All right. So DK is saying, would you suggest Dinanath Mangeshkar for DNB anesthesia? Yes, it is a great hospital. I know that they have a great ICU. Before joining any hospital for DNB anesthesia or MD anesthesia, just make sure that you get rotated in super specialties. So the more super specialties that you do, like neuro, cardiac, and regional ortho, so the more exposure you will get to different types of cases, high risk cases, so you'll become more confident as an anesthetist. Okay, so if you are in touch with any resident from that super specialty, you from that specialty, from anesthesia in that hospital, you should speak to them and confirm with them once that you get rotated everywhere. Okay, so that is how you choose a good college. All right, so I will see you tomorrow, guys, at 10 a.m. Till then, take care and keep studying. And if any doubts, you can message me on this Telegram group. Thank you, guys. Bye bye.